Hello friends, this is a continuation of our discussion about diabetes based on the chapter Diabetes Mellitus in John Murtagh's General Practice Handbook. So let's move on discussing about complications of diabetes. Complications can occur in patients with both type 1 and type 2 diabetes even despite early diagnosis and treatment. So this graph illustrates the complications of diabetes from head to toe, increased risk of cerebrovascular accidents. Then the eye complications are cataract, retinopathy and ocular palsy, especially the third and sixth nerve palsies. Then cardiac complications include accelerated atherosclerosis, myocardial infarction and arrhythmias due to vagal neuropathy. Then kidney, diabetic nephropathy and urinary infections. Gastrointestinal tract, gastroparesis and diarrhea. Then in genitourinary system, erectile dysfunction, impotence and atonic bladder are possible complications. Then diabetic amyotrophy, which is the painful wasting of the muscles. Then peripheral vascular disease, either macrovascular or microvascular complications can be there. The feet problems are the ischemia or the rest pain. Then they may develop ulcers and gangrene. Then peripheral neuropathy leading to paresthesia, muscle weaknesses, reduced reflexes and or pain. The possible skin complications include candidiasis, balanitis, vulvovaginitis, then staphylococcal infections, necrobiosis lipoitica, acanthosis nigricans and vitiligo. They also may get small muscle wasting and peripheral nerve palsy, especially the carpal tunnel syndromes. So the effect of diabetes in blood pressure is postural hypotension or hypertension. In general, patients who are having diabetes are at risk of getting hypoglycemia, hyperglycemia, ketoacidosis and dyslipidemia. Okay, let's discuss further. People with type 1 diabetes still have a significantly reduced life expectancy. The main cause of death are diabetic nephropathy and vascular disease. Vascular disease include myocardial infarction or a stroke. Diabetes causes both macrovascular and microvascular complications, but microvascular disease is specific to diabetes. Special attention should be paid to the association of type 2 diabetes with obesity, hypertension and dyslipidemia. Macrovascular complications include ischemic or coronary heart disease, cerebrovascular disease and peripheral vascular disease. So there are three major macrovascular complications that affects the heart, brain and the peripheral vascular system. An analysis of type 2 diabetes in HOPE study showed a benefit of ramipril to reduce the risk of death by 24%, myocardial infarction by 22%, stroke by 33%, cardiovascular death by 37% and overt nephropathy by 24%. So consider organs or problems affected by diabetes under the mnemonic KNIVES, KNIVES. K stands for kidney, N for nerves, I for infections, V for vessels, E for eyes and S for skin. Let's further discuss about microvascular disease. The small vessels most affected from a clinical viewpoint are the retina, nerve sheath and kidney, glomerulus. In younger people, it takes about 10 to 20 years after diagnosis for the problems of diabetic retinopathy, neuropathy and nephropathy to manifest. Nephropathy. Prevention of diabetic nephropathy is an essential goal of treatment. Early detection of the yard risk, which is microalbuminemia, is important as the process can be reversed with optimal control, particularly of blood pressure. The dipstick method is unreliable, and the preferred hospital method of 24-hour urine collection is considered impractical in general practice. So screening is done simply by a first morning urine sample to determine the albumin to creatinine ratio. So that is considered the standard test to diagnose diabetic nephropathy, especially the microalbuminuria, which is an early indicator of development of diabetic nephropathy. Then ACE inhibitors or angiotensin II receptor blockers should be used for evidence of hypertension. Then retinopathy and maculopathy. Retinopathy develops as a consequence of microvascular disease of the retina. Its prevalence is related to the duration of illness, but up to 20% of people with type 2 diabetes have diabetic retinopathy at the time of diagnosis. The European multicenter study showed that diabetes is the single most common cause of blindness in European adults in the 16 to 64 years age groups. Assessment of the fundus by an expert is recommended every 1 to 2 years via direct ophthalmoscopy with dilated pupils, then retinal photography or, if necessary, fluorescein angiography. Early diagnosis of serious retinopathy is vital since the early use of laser photocoagulation may delay and prevent visual loss. Next, move on to discuss about neuropathy. The following types of neuropathy may occur. Radiculopathy, that is diabetic lumbosacral radiculoplexopathy. Then sensory polyneuropathy, isolated or multiple mononeuropathy. Those are isolated peripheral nerve lesions, especially occurring in median nerve. Then cranial nerve palsies, the cranial nerves 3 and 6. Then amyotrophy. Next category is autonomic neuropathy, which may lead to erectile dysfunction, postural hypotension and syncope, impaired gastric emptying or gastroparesis, diarrhea, delayed or incomplete bladder emptying, loss of cardiac pain leading to silent ischemia, hypoglycemic unawareness, sudden arrest, especially under anesthetic. So those are the microvascular complications. Next, infections. People with poorly controlled diabetes are prone to infections, especially skin infections. Those are mucocutaneous candidiasis, the balanitis or vulvovaginitis, staphylococcal infections like folliculitis, then urinary tract infections, cystitis, pyelonephritis and perinephric abscesses. Then lungs, pneumonia, especially staphylococcal or streptococcal pneumonia. Then tuberculosis. Next, the metabolic complications of diabetes. They are hypoglycemia, diabetic ketoacidosis, which is usually seen in type 1 diabetes. Then hyposmolar hyperglycemia, which is commonly seen in type 2 diabetes. Then lactic acidosis. Other complications are cataracts, refractive errors of the eye, sleep apnea, depression, musculoskeletal or neuropathic joint damage, Charcot type arthropathy, tendon ruptures, then foot ulcers related to neuropathy. How to prevent diabetes? Several studies have demonstrated that it is possible to prevent or delay the onset of type 2 diabetes in those at risk. This involves intensive lifestyle intervention in individuals who are overweight with impaired glucose tolerance or raised fasting blood glucose. The ongoing DIRECT trial demonstrates that even once type 2 diabetes has been present for a few years, remission of diabetes is a realistic aim in general practice, using intense dietary measures for 3 months, followed by structured support for weight loss management. The primary strategy is to follow up the SNAP guidelines, The smoking, nutrition, alcohol, and physical activity, particularly with a view to weight loss. The essentials are healthy eating, weight loss, and physical activity. This represents an important approach that GPs can recommend to their patients at risk. Management of diabetes. The main objective for the GP are to prevent the development of cardiovascular disease and other complications. So, the GP should aim to achieve reduction of lifestyle risks. So, by optimizing weight, helping the patient to quit smoking, and encouraging them to increase their level of physical activity. Then strict glycemic control as measured by HbA1c. Target can vary with circumstances, but usually it's 7% or less. Blood pressure control, it should be equal to or lesser than 140 by 90. Control of blood lipid levels. So those are the management goals or the aims. Then the principles of management. Provide detailed and comprehensive patient education, support and reassurance. Achieve control of presenting symptoms. Achieve blood pressure control. Develop a diabetes care plan. Emphasize the importance of the diet, good nutrition, adequate protein, complex carbohydrates. Then restrict fats and sugars. Promptly diagnose and treat urinary tract infection. Treat and prevent life-threatening complications of ketoacidosis or hypoosmolar coma. Treat and prevent hypoglycemia in those taking insulin and oral hypoglycemic agents. Organize self-testing of blood glucose for those on insulin. Detect and treat complications of diabetes, neuropathy, nephropathy, retinopathy, and vascular disease. Ensure immunization schedule including influenza and pneumococcus if updated. Then monitoring techniques. Blood glucose estimation, mainly useful if on insulin. Either fasting blood glucose or postprandial can be measured. Then urine glucose is of limited use. Urine or blood ketones, that is specially recommended for those with type 1 diabetes. Then we can do 3 monthly glycated hemoglobin or HbA1c levels. Then microalbuminuria should be assessed by urine albumin to creatinine ratios. That is an indicator of nephropathy, which is at early stages. Then blood pressure measurement, serum lipid levels, renal functions, and ECG. So the blood glucose control aims or the guidelines are: fasting blood sugar is ideally less than 5.5, and if it's more than 7.7, that is suboptimal or unacceptable. Then 2 hours postprandial, ideally is less than 7. If it's more than 11, it's not acceptable. Then HbA1c level, ideal is 7 or less. Then if it's more than 8, then it's suboptimal control. Then blood glucose monitoring at home. This is done using a glucometer. A wide variety of meters and smartphone apps are available, and patients will require advice about what suits them. How often to check and when to check. For patients with type 1 diabetes, they should check blood sugar levels 4 times a day, before each meal and before the bedtime. At first, and for problems, twice a day. And may settle for about 1 to 2 times a week if the patient is having good control. So at first, they should check blood sugar levels 4 times a day, before each meal and before the bedtime. And once the blood glucose control is optimum, then they can check in 1 to 2 weeks time. Then patients who are having type 2 diabetes, and important for those on insulin, not routinely recommended for oral medication. So blood sugar control is usually good for patients who are already on insulin, but for those who are only on oral medication, that's not usually indicated. So what is more suitable is HbA1c. Then more useful for pregnant women, frail, elderly, heavy machinery operators or symptomatic hypoglycemia. Then goals of management. All people with diabetes should be encouraged to maintain the following goals. Blood glucose level ideal is 4 to 6 millimoles per liter when they are fasting. Then postprandial is around 8 to 10 millimoles per liter. HbA1c level should be 7% or less. Then total cholesterol less than 4 millimoles per liter. LDL cholesterol less than 2 millimoles per liter. HDL cholesterol 1 or more millimoles per liter. Then non-HDL cholesterol should be less than 2.5 millimoles per liter with triglycerides less than 2. Then blood pressure should be less than 140 by 90. And if the patient is having proteinuria, the optimum blood pressure control is either or lesser than 125 by 80. Then BMI, the body mass index, should be 18 to 25 where practicable. Then urine albumin excretion should be less than 20 micrograms per minute timed overnight collection or less than 20 milligrams per liter in on a spot collection. Then albumin creatinine ratio should be less than 2.5 milligrams per millimoles in men and less than 3.5 milligrams per millimoles in women. Smoking should be stopped and alcohol intake should be limited to 2 or lesser standard drinks or 20 grams per day for both men and women. Then exercise at least 30 minutes walking 5 or more days a week is recommended. Capillary blood glucose is approximately 7% higher than the venous blood. Then glucometer error is usually plus or minus 5%. Glycated hemoglobin, HbA1c, which normally comprises 4 to 6% of the total hemoglobin, is abnormally abundant in those with persistent hyperglycemia, reflecting suboptimal metabolic control. Glycohemoglobins have a long half-life than their measure reflects the mean plasma glucose levels over the past 2 to 3 months and hence provides a good method of assessing overall diabetes management. HbA1c should be checked every 3 to 6 months. Next, let's move on to discuss about type 1 diabetes. The three main objectives of the treatment of type 1 diabetes are to maintain good health, free from the problems of hyperglycemia and hypoglycemia, to achieve proper growth and maturation for children and protect the fetus and mother in a mother with type 1 diabetes, then to prevent arrest or delay long-term macrovascular and microvascular complications. Insulin regimes for type 1 diabetes. The most commonly used insulin injection preparations are the artificial human insulins. They are classified according to their time course of action. There are rapid acting and short duration, insulin lispro and insulin aspart. Then short acting neutral are the regular or soluble insulin that we often use. Then intermediate acting insulins include isophane or insulin lente. Then there are some long acting preparations. Those are ultra lente or insulin determa or insulin gargline. Then premixed or short intermediate include biphasic insulin, which are neutral plus isophane. So apart from all these preparations, insulin can also be administered as a continuous subcutaneous infusion. So, starting insulin. It's important to use the simplest regime for the individual and to provide optimal education about its administration and monitoring. Full replacement of insulin is achieved by using 2 to 3 or 4 injections per day. However, automated glucose monitoring linked to smart insulin pumps can make an injection decision every 5 minutes for available insulins. Ultra short acting insulins usually peaks after 1 hour of administration, and the action can last about 3.5 to 4.5 hours. Examples include the insulin Lispro or Humalog, insulin Aspart, Novorapid, or insulin glulicine, Apidra. Then short-acting insulins, peak onset of action is after 2 to 5 hours. The duration lasts about 6 to 8 hours. Those are the neutral or regular. Examples of the commercial brand names are Actrapid, Humulin or Hypurine Neutral. Then intermediate acting insulins, the action lasts about 12 to 24 hours. Those are the isophane insulin. The brand names usually Humulin NPH or Protophane or Hypurine isophane. Then long-acting analogues include insulin Glargine and insulin Determi. Insulin Glargine can last up to 24 to 36 hours and insulin Determi can last up to 24 hours. Then there are premixed or combinations of short and intermediate acting insulins. Those are the Humalog Mix 25, which contains insulin Lispro 25% and Protamine 75%. Then Lispro 50% and Protamine 50% makes a Humalog Mix 50. So like that, there are premixed combinations of short and intermediate acting or short and long acting insulins. The premixed 2 injections, they are biphasic system. So they can be given twice a day, 30 minutes before breakfast and before evening meal. So typically starting dose is about 0.3 international units per kilogram body weight per day. Usually for a 70 kilogram person, we can start with 10 units twice a day. There can be 3 injections per day, that is short acting insulin before breakfast and lunch and intermediate or long acting insulin before the evening meal. Then there's 4 injections system, that is called the basal bolus system, where short acting insulin before breakfast, lunch and dinner. So those are the 3 boluses that we are giving, and the basal is maintained with an intermediate or long acting insulin given at the bedtime. So that's why they get 4 injections. So if we go into more details, this graph illustrates the time course of insulin injection regimes. So these rapid increments are the short acting insulin, the boluses that we are giving. So in this regime, we are giving 3 boluses with breakfast, lunch and dinner, and the basal is given at night and it maintains desirable blood level throughout the day. So this is twice daily short acting and an intermediate acting combination. Here these are the boluses that we are giving, and these are the intermediate acting insulins that we are administering, that helps to maintain a basal level of insulin in the blood. Insulin requirements often vary significantly, even in the same individual under different lifestyle conditions. The rapid acting analogues can be taken with meals. How are we giving the insulin injections? At what time? Suggest the patient develops a set routine, such as eating meals on time and giving the injection about 30 minutes before the meal. It is administered into subcutaneous tissues. The best place is the abdomen. Leg is also acceptable and it's advisable to keep to one area, usually the abdomen, to avoid injections into the arms near joints and the groin. The injection should be given at a different place each time, at least 3 centimeters from the previous injection. So this reduces the risk of the development of lipodystrophy. The means of delivery is the insulin syringe or the insulin delivery pen. So the desired site is the abdomen and anterior thigh can also be used. How are we going to administer? Pinch a large area of skin on the abdomen between the thumb and fingers and insert the needle straight in. After withdrawing the needle, press down firmly, and patients are strictly advised not to rub or massage over the injection site for 30 seconds. You should press down firmly for 30 seconds after withdrawing the needle, and alcohol swabs are unnecessary. Guidelines for the patient. Take your insulin every day even if you feel ill. Do not change your dose unless instructed by your doctor or you are competent to do so yourself. Then injection sites should be inspected regularly because lipohypertrophy or lipoatrophy can occur. Sick days. Have a pre-arranged action plan. Never omit the insulin dose even if the illness is accompanied by nausea, vomiting or marked anorexia. More top-up insulin is usually required. That can be administered via rapid or fast-acting insulin preparation. Then maintain glucose. Keep regular blood glucose checks. A concern if it's more than 15 millimoles per liter. Then seek support and help. Sport. Encourage sporting activities. Careful planning and monitoring of blood sugar is required. Insulin doses may need to be adjusted before activities. Additional carbohydrate may be needed. Then glycemic targets for adults with type 1 diabetes. HbA1c target is 7%. Then for blood glucose, fasting or pre-meals should be around 4 to 7 millimoles per liter, and postprandial target is 5 to 10 millimoles per liter. Okay, that's fairly detailed about type 1 diabetes. Let's discuss about type 2 diabetes in a separate video. So, thank you very much for listening. We'll keep in touch.